Hi, everyone. Thank you so much for joining us today on our MDA Advocacy Institute, where we'll be talking about the Build Back Better Act and what it means for the neuromuscular community. My name is Mark Fisher. I'm the Director of Advocacy Engagement here at MDA, and we're thrilled to have you. This is our final one of 2021. I can't believe that, but we're ending on a great topic for you today. If you have any questions during the webinar, feel free to put them in the Q&A box on your screen, and we'll do our best to answer them as soon as you put them in, or at the end of the webinar, we'll have time for some Q&A. So what are we going to talk about today? First, we're going to talk a little bit about some breaking news from Capitol Hill. We had some very exciting things happen last week that we just wanted to make sure you're aware of. And then we'll go into the crux of the presentation, which is Build Back Better. This is a piece of legislation that has gotten a lot of news. It's been in news for quite a long time. It's a very big piece of legislation that covers a wide variety of things, which we'll talk about. But there are key provisions that we believe will affect the neuromuscular community. So we wanted to make sure you were aware of those key provisions and what they were and how they'll affect the community. After that, we'll talk about the road ahead. And of course, we'll have Q&A at the end of the session. So we are joined by an all-star panel today. We are thrilled to have some amazing speakers for you. The first is Jason Resendez. He is the Executive Director of Us Against Alzheimer's Center for Brain Health Equity and the Chief of Staff of Us Against Alzheimer's. From clinical trial inclusion to paid family leave for family caregivers, he champions brain health equity at every level of the healthcare system. In 2020, Jason was recognized as one of America's top 20 influencers in aging by PBS Next Avenue. So we're just thrilled to have him. We're also going to be joined by Katie Berg. She is the Director of Federal Government Affairs for Leukemia and Lymphoma Society, where she's been there since 2019 and covers access to care-related issues, including Medicaid and the Affordable Care Act. Prior to joining LLS, she served in the Office of Legislation at the U.S. Department of Health and Human Services under the Obama administration. She also spent time on the Hill working for both Senators Donnelly and Harkin. She currently lives in D.C. with her husband, Peter, and 2 Basset Hounds, which I can attest to adorable Basset Hounds, Mabel and Olive. So we're thrilled to have both of them. We're also joined by Paul Melmeyer. He is MDA's VP of Public Policy and Advocacy. And of course, I'm Mark Fisher, the Director of Advocacy Engagement. So with that, Paul, I'll turn it over to you to kick us off.
All right, well, thank you very much, Mark, and welcome everybody again to our final Advocacy Institute of the year. We're thrilled to have you, and we're also very thrilled to share some very good news from last week. For those of you who follow us on Twitter, Facebook, really in any of the ways in which we can reach you, you very well likely saw that there was a big bill that passed last week in the House of Representatives, and that was the Act for ALS. Now, ALS is in the name, so of course this is a bill that would be very important to those within the ALS community, including the bill would fund access to expanded access for those with ALS. But it's also a bill that would do a lot more for the entire rare neurodegenerative and neuromuscular disease communities, including creating a public-private partnership between FDA, NIH, and stakeholders to discuss drug development in ALS and neurodegenerative diseases. It would create an FDA action plan. It would also fund millions of dollars in new clinical grants at the FDA. So last week was a huge step forward with this piece of legislation passing the House 423-3. So clearly quite the bipartisan piece of legislation. Obviously, there's more work to be done. We're now moving over to the Senate to try to get it out of the Senate as quickly as we can. Already we have 58 co-sponsors on the Senate side, which is really amazing and quite a testament to all the great work that the advocacy community has been doing to socialize this bill in the Senate and gain supporters. And we're hopeful that we're going to be able to pass it as quickly as we can out of the Senate to get to the president's desk sometime, if not in the next couple of weeks, certainly within the next month or two. So really excited about last week. Just a huge thank you, not only to our partners, IMALS, ALS Association, and many other ALS groups and neuromuscular disease groups more generally for supporting this, but of course, all the hundreds, if not thousands of advocates who have called and emailed, tweeted at, in any way reached your congressperson, your senator for supporting the legislation. So really excited about this milestone. We'll be sure to update you all as we continue advocating on the Act for ALS. Let's move on to our topic for today, which is the Build Back Better Act. As Mark had already alluded to, obviously this is really the topic du jour in Washington. It is the huge bill that has been the main focus of Congress really for the last several months, if not longer for that matter, as many of the priorities of President Biden and of Democrats on Capitol Hill are included within this legislation. It's called many different things. It's called reconciliation because it's going through the very esoteric reconciliation process in the U.S. Senate. Similarly, because of that, it's also can be considered a budget bill because in order to go through reconciliation, it has to have federal budgetary implications. And then as others call it the social infrastructure bill, because we already had the physical infrastructure bill that you all know passed and was signed into law just a little while ago. This is considered to be the accompanying social infrastructure bill. So we wanted to talk a little bit today about the legislation because there are several pieces of this bill that could have really, really important impacts for those with neuromuscular diseases. Now, there are, of course, many parts of this bill that don't really fall within MDA's focus. For example, several parts of the legislation that have to do with childcare, or with the child care tax credit, or with universal pre-K, or other aspects that are meant to expand services for those with children, but also other services for those without children that really fall within the focus of President Biden's priorities, as well as those up on Capitol Hill in the Democratic Party. There is a lot of provisions pertaining to climate change and things pertaining to energy tax credit, clean energy tax credits, and trying to modernize our energy infrastructure, as well as the energy that we use, all to combat climate change. And then just a plethora of other provisions that don't really kind of neatly fall within any specific category, but might have to do with immigration or with education or with a number of other very important issues, all of which are included within various different versions of the bill. Some provisions included in some version, others in other versions, but all of which are prioritized in many communities. But again, are not really the focus of the Muscular Dystrophy Association, doesn't fall specifically within our conversation today. So we're not going to focus on those. I can assure you there are many advocacy groups out there if you want to focus on those issues to advocate on climate change, on health, on child care, on universal pre-K. The list goes on. So let's talk a little bit about what MDA does support within the legislation. And there are going to be each of these things we're going to focus on today. So for one, we're going to talk about paid leave. Paid leave can be incredibly impactful for those with neuromuscular diseases and their caregivers. We're going to talk about the provisions that would actually move us away from the discriminatory and poverty perpetuating use of the subminimum wage for those with disabilities. We're going to touch on the funding that would go to home and community-based services under Medicaid programs for those with disabilities, as well as those who require care or other services in the home. We'll also talk about some of the provisions that would solidify or expand access to health insurance, whether that be private insurance or Medicaid. And then we'll touch on the provisions that have to do with drug development, as well as drug pricing, all things that we know are very important to the neuromuscular disease community. And consequently, that's why we're calling for these provisions especially to be passed as part of the Build Back Better Act. Yes, the legislation is polarizing. It is political in many ways, with certainly one party being very much in favor of it and the other not. But what we do at MDA is we look at any piece of legislation and we evaluate it for whether it could benefit those with neuromuscular diseases. And we know definitively these provisions by and large would benefit those with neuromuscular diseases. Consequently, we're supporting it. Consequently, you'll hear several times throughout today's conversation, we'll be asking for your support as well. So we want to start on our next slide with paid leave. And again, we are so grateful to have Jason Resendez with Us Against Alzheimer's with us today, because Jason has truly been a leader among the advocacy community in pushing for paid leave, not just within the Build Back Better Act, but within all contexts, truly a leader on this issue. So Jason, first of all, thank you for joining us today. And then second of all, can you just tell us a little bit about what paid family and medical leave is?
Sure. Thanks so much, Paul, for having me, and for all of you for joining today to learn about how you can leverage your voice to advance these important policies. So paid family and medical leave is an important policy that if enacted, and that enables workers to take time off in order to care for themselves, dealing and navigating a serious medical condition, or for a loved one. And to have that time off paid and protected. Right now, the US has a policy in place called FMLA, the Family and Medical Leave Act, which was passed in 1993, which enabled workers, and not all workers, millions of workers are not protected by FMLA, but enables many workers to have unpaid time off to provide care for themselves or for a loved one. So this policy, paid family medical leave, is something that the advocacy community has been really pushing since the passage in 1993 to expand, to ensure that that leave can be paid for, given how important it is to be able to balance care and also your one's financial mobility. That's really critical from a economic justice perspective, from a racial justice perspective, and from a gender equity perspective as well. So we think that paid family medical leave is absolutely essential as a policy to protect families as they're navigating complex care issues.
Thank you, Jason. So on the webinar with us today are caregivers of children with neuromuscular diseases, parents of children with neuromuscular diseases, individuals with neuromuscular diseases themselves, caregivers, loved ones, those who could find this important. Can you tell us why the neuromuscular disease community, or really just the patient and caregiver community more generally, should find paid family medical and leave important?
Yeah, I think, next slide. We can go to the next one. Great. I think one is that I'm sure many of you, just like in the dementia community, which I'm most familiar with, are providing that care for your child or for a loved one, while also trying to balance work. In fact, 1 in 5 full-time US workers are a caregiver, providing care for someone living with a complex medical condition or with a disability. And that comes at a steep cost, right? Folks having to make hard decisions between providing that care or being able to stay in the workforce. And what we see is that for communities, for individuals with lower levels of education, with lower wage earning jobs, they're having to choose care over their workforce participation, which has really steep effects for them as individuals and as families. Next slide. In fact, what we see is that 44% of caregivers have had to cut back at work to provide care. So more and more we're seeing the negative impacts of caregiving without a policy like paid family medical leave in place that guarantees wage replacement, for example, that guarantees workforce protections as folks are trying to navigate care and work. What we've seen in research that we've done is that overwhelmingly folks are afraid to utilize paid family and medical leave policies that are in place because of a fear of retaliation from their employees, for not really being able to navigate the process because it's such a patchwork system that's in place right now. So national policy can help us address some of those issues by, one, guaranteeing wage replacement, by guaranteeing workforce protections, and letting families balance providing care for a complex medical condition while also staying in the workplace. And that's really critical, again, like I said, for families at the lower income levels, particularly families of color. And we've seen this play out during the pandemic. Next slide. What we see is that when we look at the negative impacts of workforce participation on families who don't have paid family medical leave, we're seeing higher percentage of impact on people of color. So higher rates of people of color who've had to quit their job to provide care, or have had to reduce hours or go part-time to provide care. And so there's a strong, I think, equity aspect to this as well, in addition to the importance of being able to utilize paid time off to navigate medical needs and caregiving needs. Next slide. And I think what's interesting is, and why your advocacy is so important, is that this movement, the paid family medical leave movement, has really been focused on, for the longest time, parental leave. And because of that, which is parental leave is absolutely critical, but oftentimes policymakers are really listening to the loudest voice. And so medical leave and family caregiver leave has often been negotiated out of packages. So for example, in our national response to COVID, caregiver leave and medical leave was shortchanged compared to parental leave. And so at the same time, medical leave makes up more than half of leave claims in states where there's a paid family and medical leave policy. So it's absolutely critical to have the voices of individuals who are impacted by complex care and medical needs to raise their voice about the importance of paid family leave to enable them to stay in the workforce as long as possible as they provide care. And it's without that voice, without that mobilization, it'll continue to be easy to negotiate this community out of packages like Build Back Better. And so what we're very excited about is that there's been a lot of momentum around the Build Back Better plan and around the larger paid leave community with a focus on comprehensive leave, really pushing for leave across what we call eligible purposes. So not just providing leave for newborn babies, but also being able to provide leave for a loved one with a serious medical condition or an aging parent, for example. And so that's been an exciting, I think, development, a lot of energy, a lot of solidarity around this, but it's absolutely important because as you mentioned, Paul, the name of the game is making a deal, right? And so folks are really looking at where they can, cut. And so having your voices and sharing your stories is really critical as we get really down to the wire here on Build Back Better, and folks are looking to make a deal. And you have folks like Senator Manchin, who says he's not hearing enough about paid family and medical leave from the medical leave perspective or from the caregiving perspective. Absolutely critical that we have your voice around this. And there's some really good stuff it's not perfect, but definitely some good things that are happening and that are part of the package.
Yeah, so Jason, tell us just a little bit more about that. And we'll get back to how those on our webinar today can make their voice heard and can tell their senators, their representatives, their elected officials how important paid leave is. But before we get there, can you tell us a little bit about kind of the different versions of this policy that are out there, whether it be Senate Finance or whether it be any other version you want to speak to for that matter? Just tell us a little bit about the nuts and bolts of exactly what kind of policies we could be looking at here.
Great. Next slide. So the good thing is we were very worried as a larger paid leave movement about the Senate Finance bill not including paid family medical leave. And text came out recently, and we're very pleased to see that included paid leave provisions that really mirror the House passed Build Back Better around paid family and medical leave. And that was really a saga. That actually had been cut about 3 weeks before the passage of Build Back Better. Paid leave was pulled out. Thanks to the advocacy of folks like you and others, we're able to get that added back in. What we did see, though, was a reduction in weeks. What we think is the gold standard is 12 weeks of paid family and medical leave That got negotiated down to 4 weeks, which we still think is an important amount of time. It's certainly better than the current status quo, which is 0 weeks of paid family and medical leave. But that duration we think is important and worth fighting for. In our own research, for example, of the dementia community, we found that the average use of paid family medical leave for dementia caregiver was between 4 and 8 weeks. So it's still within that window. So what the Senate Finance Bill includes is 4 weeks of comprehensive paid family medical leave. So that means not just parental leave, but allowable purposes for caring for a family member with a serious medical condition, caring for your own serious medical condition, for an aging loved one. It also looks and expands a definition of family. So for example, we have an advocate in Ohio, which doesn't have paid family medical leave, who was unable to use FMLA to provide care for her aunt because that was not included in the definition of family. And so the Senate Finance Bill revisits how we define family and expands that to cover more individuals, given the shifting ways that families are constructed, intergenerational households, et cetera. It also is a permanent program, which we think is really critical, that provides certainty to workers, employers, and states. It also incorporates and provides funds to states who have a current paid leave program to be able to tap in to either pay for those paid leave benefits or to supplement and improve those paid leave benefits at the state level. And it also includes what we call progressive wage replacement. So basically lower income earners get more of their wages replaced, higher income earners get less of their wage replaced, but it's one of the ways why we think that things like means testing are not needed for paid family medical leave, because that's already built into the program design. So I'd say the big things are 4 weeks, comprehensive leave, progressive wage replacement. So it's not perfect, but it's better than the status quo, and it's going to put us in the right direction in terms of being able to support families as they navigate work and providing complex medical care and caregiving.
Yeah, 100%, Jason. And I would add to that. As you said, the House just a few weeks ago, passed their version of the entire Build Back Better Act. The Senate's working on their version right now in the Senate Finance Committee. There are different committees who are committed to working on their different parts of it. Senate Finance, of course, is working on paid leave, and that's why we're very grateful to see this come out of the committee. One other thing I want to mention just before I turn back to you on the question of how advocates on the line today can help, just a plug for the Q&A box. Feel free to send in questions. We already have one question that I'm gonna we're gonna do our best to answer here in a moment, but for everybody else, please also submit questions throughout our discussion today, whether it be paid leave, any of the other topics we cover. We're gonna try to leave some time at the end for Q&A. So please, down in the Q&A box, down at the bottom of your screen, feel free to put something in there. But before I get to that question there, Jason, one more question for you. How can advocates help? Where does the neuromuscular disease patient community, where does any community for that matter, that could be benefited by the paid leave policy within Build Back Better, how can they help get this actually across the finish line?
Yeah, that's a great question. I think what we found is the importance of storytelling. So sharing your story with your member, calling and leaving a voicemail in their inbox, talking about why you think paid family and medical leave is important in the Build Back Better package because of your personal experience. So anything you can do to share your story of how caregiving has impacted your work. You are likely in those stats that I highlighted, having to pull back hours, having to make work adjustments due to caregiving. Those stories are really critical. And what we're hearing right now is that those are the stories that are going to make the difference as folks really come down to the line on what's going to be included and what's not. In fact, we've heard specifically from the White House and from staffers at Senator Manchin's office about the importance of those stories and being relentless in sharing those stories. So your voice is really critical right now.
Absolutely, Jason. Couldn't say it any better than that. Let me just get to one question that was submitted into our Q&A box. And Mark, thank you for, in the chat box, posting the link that you all can follow who are joining us today for sending a letter, sending an email, calling even your senator, calling your representative, asking for them to support the provisions of Build Back Better that we know to be very important to our community, including paid leave. And we'll get back to that in addition just a little bit further. But Jason, while we have you as the expert on the line, we had someone write in asking, why doesn't the government just pay caregivers to take care of those with disabled adult children instead of having strangers coming into the house? I'll start if you want to think about your response to that. For one, in many ways, this is what that is, that we would allow for adult parents of adult children who require in-home care who are otherwise working and have a professional care attendant come to the house. If that care attendant is unable to come to the house, the wages could still be replaced through paid leave by this program for the parent who has to take work off to then come back and assist with the caregiving. But Jason, you see the question in the Q&A box. How would you answer our attendee who asked that question?
Yeah, I think that, I think that's a really great point, right? How can we better center care in the home among family? I think paid leave is one element of that. Things like caregiver tax credits, the Credit for Caring Act is another component of that. We know that at the state level, some states do allow for home health aides, for example, to be family members. Some states don't. So I think that's a really important point. And right now, there is a national plan being developed through the RAISE Family Caregiver Council, which is a new council established by the RAISE Family Caregiver Act, which was passed in 2020, to develop recommendations for developing a national strategy for caregiving. And many of those priorities or recommendations will be developed is around that idea of how to empower families to provide care in home. So that's something I'll definitely take into our work in that. And thanks for the question.
Yeah, absolutely. I totally agree with that, Jason. So we're going to move along from there. But before we do, Jason, again, thank you so much for sharing your expertise and your advocacy with our community today. If we're able to stick around to the end, just in case we have a few other paid leave-oriented questions, would love it if you can. If you can't, that's also just fine. But Jason, again, a big thank you to you. So let's move along with our agenda here, as we still have plenty to talk about. And I saw a few more questions coming into the chat box. We'll get back to those in just a little bit. So we wanted also to speak to the provision within the legislation that would help move us away from the use of the subminimum wage for those with disabilities. And just as a minute or so of background, as you all may know, the subminimum wage is still allowed to be used in certain states for individuals with disabilities. And that subminimum wage is, of course, oftentimes dramatically lower than what the minimum wage otherwise would be within that specific state. Now, this practice has been argued to help actually facilitate employment for those with disabilities by allowing employers to hire an individual with a disability, but not having to pay them as much as their colleagues. Now, not only is this discriminatory, but because the subminimum wage can be as low as just a handful of dollars per hour, it also perpetuates a cycle of poverty for many with disabilities who are allowed to be paid that little by the law in these states. So an additional provision within Build Back Better that we are very supportive of is a grant program that would actually allow the federal government to fund states and these businesses that have previously used the subminimum wage to actually pay individuals with disabilities at these locations a competitive wage with everybody else within that same job, within that same organization. So it helps transition states and businesses away from using the poverty-inducing and discriminatory subminimum wage, and would help facilitate individuals with disabilities making a competitive wage with their colleagues. So there is a grant program of about $200 million included within the House-passed version of the Build Back Better Act. And it is something that we're going to be certainly advocating for in the Senate, to ask that they also include this grant program so that we can move more and more individuals with disabilities out of having to be paid the sub-minimum wage. A second thing that we wanted to discuss is the home and community-based services provisions within the Build Back Better Act. Here on your screen, you see Senator Bob Casey, who is one of the major proponents of this legislation and of this part of the legislation, certainly. And home and community-based services are services that are put forth through state Medicaid programs that allow for individuals with disabilities as well as older individuals to be actually taken care of within their home, rather than within a facility, within an institution, whatever it happens to be. And currently these programs exist within states, but they are severely underfunded and there are huge waiting lists. We know in many states with home and community-based services programs, waiting lists for access to these services under their Medicaid programs can be years long. It can take years for an individual having first signed up for these services to actually receive them, if they ever do, for that matter. So consequently, the Build Back Better Act would actually infuse an enormous amount of money. Not quite as much as what advocates were initially asking for, but still a good amount of money from the federal government to states to do several things. For one, to actually reduce the backlog of those who are on the waiting list to access home and community-based care, to improve state programs for home and community-based care, and to ensure that the actual market for care attendants, for care specialists, for those who are actually providing the care in the home is robust and that they are paid a competitive wage. So we're not just opening up eligibility, or not necessarily opening eligibility, because eligibility is already fairly wide open in many states, but reducing the backlog of the waiting list, that there are going to be those professionals who are there ready to actually provide the services in home. So we are very supportive of this provision within Build Back Better, because we know how important it can be for those with neuromuscular disabilities to be able to access care in the home rather than outside of the home. Just how beneficial it can be to be able to stay in the home and receive the same quality care that an individual with neuromuscular disability would receive outside of the home. So this is the third provision that we wanted to brief you all on today as important for the neuromuscular disease community that is within the House-passed Build Back Better Act that we're hoping will be included within a Senate version of Build Back Better that we again hope will be passed in the not so distant future. So to move along to the next slide, we're going to welcome in our next guest, Katie Berg from the Leukemia and Lymphoma Society. Katie, again, very grateful to have you with us today as our expert on all things access to healthcare, and we're going to be talking about two provisions today. The first is pertaining to advanced premium tax credits, and the second has to do with Medicaid expansion, the Medicaid coverage gap. So Katie, I'm going to turn to you first on the advanced premium tax credits. Can you just tell us what these tax credits are, how they help individuals purchase insurance, and then the intersection with these tax credits to the Build Back Better Act?
Great, thanks, Paul. It's a pleasure to be here with you today. So the Affordable Care Act revolutionized affordability, and that's not to say that it fixed affordability. It just helped a number of consumers that were previously locked out of the market due to their health status, due to where they lived, or if they had a pre-existing condition. And so the ACA, when it was passed way back more than 10 years ago, reformed almost all types of insurance and took steps towards making insurance more affordable. So it did things like closing the Medicare donut hole, but most importantly, it helped to create a tax credit for the individual market. So for folks that didn't have offers of employer-sponsored insurance, and who were otherwise ineligible for things like the veterans coverage or Medicaid, could now get a benefit from the government to help offset the cost of their health insurance premiums on a monthly basis. So advanced premium tax credits are exactly what they sound like. They're tax credits provided by the government to offset your monthly premium. You get them in advance of your annual tax return, and they're paid directly to issuers. So the best part about this is that patients and consumers don't ever have to deal with sending money in from the government, receiving it and sending it out. It goes directly into those premiums for folks that are eligible. And people who are eligible are folks who fall in between 104% of federal poverty. Federal poverty varies by state. It can be very high in some circumstances if you live in a city like New York City, where incomes and cost of livings are very high, but it's still difficult to make ends meet, and they can be very low depending on where you live, including in rural areas. So we'll go to the next slide. So you guys all might remember that we had another large bill passed earlier this year called ARPA. ARPA was related to a lot of COVID relief and had a lot of things in there to kind of help prop up the healthcare system in the midst of this global pandemic that we're in. But one of the most important provisions in that included increasing generosity for advanced premium tax credits, or APTCs. So you'll see here, we have kind of an ugly chart, one of which says what the tax credit benefit used to look like as a percentage of your federal poverty level. You'll see here that folks between 100 and 133% had 2.7% of their annual income go towards their APTC, meaning that you could recoup those costs and apply them to your premiums every month. Now the percentage that you'll be paying for that, if you're within that particular category after ARPA, is 0%. And you'll see that they have readjusted the percentages of your annual income per year to go down, so that you will be paying a lower amount of your annual income in terms of premiums. And that includes, if you look at the over 400%, before there was no cap on the amount of cost that you could pay for your premium every month, but here you'll see that they capped it at 8.5%. So it is a really good benefit. The problem with ARPA, as with many things that the federal government does, is that it's temporary, right? And so we're hoping, if we're going to move on to the next slide, please, that this can be extended. And so you'll see here what the ARPA impacts on APTC, or on monthly premiums, look like before and after passage. Those blue bars there represent the amount of cost that people at different age, or excuse me, not different age, but in different income brackets experience. And you'll see that folks down towards the lower income brackets will now be able to receive $0 premium coverage. A significant improvement from where we were prior to ARPA. One more slide for me, Mark. So one of the things that we want to do in BBB, Build Back Better, reconciliation, the budget work that we're doing right now, is continue those into the future. BBB does that. I think one of the things that organizations like ours, like LOS, the Neuromuscular Community, and many others have been advocating for many months now at this point, is making those permanent. But as we all know, you've been seeing that there's a negotiation process happening up on the Hill, and part of that was including the ARPA extensions in BBB on a temporary basis. So now, as it stands today, and that's a big if, as it stands today, BBB would extend these increases in APTC generosity and eligibility through 2025, and then we'll hit a sunset. So again, I think you've heard this today, that it's always good to fight another day on these issues. We didn't get permanent paid leave. We didn't get a lot of permanent provisions here, but it's good to have something to build on for the future. So the next thing that I think we wanted to transition to, and we'll hit the next slide here, was some of the Medicaid provisions. Some of the Medicaid provisions include things that are related to Medicaid expansion. Medicaid expansion was an original provision in the Affordable Care Act way back in the day that required states to extend eligibility to otherwise ineligible populations, mainly single adults without children, whose income was below 138% of federal poverty level. However, we all know that the Affordable Care Act has been through multiple rounds of litigation at this point. And so through a case called NFIB v. Sebelius, this became optional. And so many of our organizations have been working with states to pass Medicaid expansion since that time. Right now, we're sitting at all but 12 states having Medicaid expansion, with more than 2.2 million eligible individuals uncovered. That means that there are 2.2 million folks that under the original ACA would have been able to receive high quality, low cost care through the Medicaid program. And we're going to slip on to one more slide here. And this is just a visual depiction. So marketplace subsidies for the ACA insurance market kick in at 100% at federal poverty level. However, many state Medicaid programs don't kick in at, until below a certain threshold. So you'll see here that for a family of 3, you don't qualify for Medicaid in the state that this is visualized for, and if you make over 41% of federal poverty level. So that's for this family of 3, based on a median eligibility, it's less than $9,000 a year. So incomes have to be very low, which means there's a lot of people between 100% and Medicaid eligibility in many states. So this is just a visual depiction of kind of those folks that fall into the coverage gap. Next slide, please. So what does the BBD do to fix this? And again, it temporarily closes the Medicaid coverage gap. It basically allows folks that are currently in the coverage gap to opt into a federal solution using the ACA insurance markets, but for $0 in their premiums. We know that low income individuals and families are very sensitive to costs, that many people who need assistance with their coverage will not use it unless it is very low or no cost to them. And so basically what it does is it takes the existing ACA insurance market and tweaks it so that it is more appropriate for low income individuals and families. It also changes the benefit structure. Medicaid is a much more generous benefit structure, and it takes the ACA marketplace structure and enhances it so that folks who need Medicaid benefits have the ability to get more over time. This will scale up over a period of years, and there are a variety of phases here. But again, it also works very hard to, at the same time, not take away some of the incentives that were passed as part of ARPA and other legislation over the previous years to encourage states that have not yet expanded to expand their traditional Medicaid programs. You'll see here that we have a graph that just depicts the significant impact that this will have on health equity and access to coverage over the years, similar to the way the Affordable Care Act has done. So you see how these two policies, the APTC enhancements and fixing the federal coverage gap, or the Medicaid coverage gap rather, really help to turn up the volume and on coverage in our country, which is really important for core health outcomes. So I think we'll switch to the next slide. Great.
Yep, that's it, Katie. And thank you again for the very comprehensive look at these two very important provisions within Build Back Better. And so we do want to move along, but again, please, everybody, if you have questions for Katie on advanced premium tax credits, on the Medicaid coverage gap, on the work that we're all doing together to expand coverage, expand access to health insurance more generally, please do put them within the Q&A box. And I see we have had a few additional questions down in the Q&A. We'll address those certainly at the end. So you've heard us talking a lot about things that we like, things that we believe will be highly beneficially impactful for the community: paid leave, moving away from the sub-minimum wage, access to health insurance, home and community-based care services. Now, the news is not uniformly good, we will say, at MDA within the Build Back Better Act. And there is one provision that we are particularly concerned about, and that has to do with the orphan drug tax credit. So for those of you who might not know about the orphan drug tax credit or what it is, it's a tax credit that incentivizes pharmaceutical companies to develop drugs for rare diseases. And you know, for those of you on the phone, you likely know the neuromuscular disease that you have yourself, or your loved one has, or that you advocate for. It's a rare disease. Every single neuromuscular disease that MDA advocates for or serves the community for qualifies as a rare disease under federal government statutes. So consequently, the orphan drug tax credit actually incentivizes companies to develop new drugs or new uses of existing drugs for rare diseases specifically. Right now, there's a 25% tax credit available to companies for qualified clinical testing expenses. Now, the issue that we're encountering within Build Back Better is actually there is a provision that would roll this incentive back. Now, it wouldn't necessarily change the percentage of tax credit that's available. It would still remain as a 25% tax credit for companies developing drugs for those with rare diseases. However, what this provision would do is limit the eligibility of actually getting the tax credit for a pharmaceutical company to only the very first indication that is approved for a new drug. So let's take a new drug that treats an inflammatory disease, for example. If it's a rare inflammatory disease, then the orphan drug tax credit under this provision can be taken for the very first indication that has been approved. 25% tax credit incentivizes the company from entering this space in the first place. However, what this provision would do is change the law so that any additional use of this drug in a rare disease, could be a completely different rare disease, does not qualify for the orphan drug tax credit. So the incentives to actually repurpose existing medications, the incentives to keep researching existing medications would shrink if this provision was passed as part of the Build Back Better Act. And on the left side of your screen here, you see Richard Neal, who is the chairman of the Ways and Means Committee in the House of Representatives, and it was his committee that authored this provision in the very first place. Now, let me tell you just another moment on the intersection that this provision could have with neuromuscular diseases. There are currently 2 therapies that have been approved for neuromuscular diseases, one for myasthenia gravis and another for dermatomyositis, that were actually not the very first indications on that drug that were approved by the FDA. Instead, they were a 2nd, 3rd, 4th, 5th indication. They were an additional indication on an initial drug that the company actually did the clinical trial to ensure that that therapy was safe and effective for. And they got, under the current law, the orphan drug tax credit for doing so. If this was to pass, the company would no longer be able to take this tax credit for that kind of use. And we know that there are going to be future examples of companies looking at neuromuscular diseases, considering if there are additional uses of their existing therapies within neuromuscular diseases that haven't been studied, that haven't been tested, but could be safe and effective, but the incentives for actually doing that research will be less. So this is actually something that we oppose within Build Back Better, and that we're hoping, even though it was included on the House side, it was included in the House bill, that they'll choose not to include it on the Senate side. So move on to the next slide, just one more provision within Build Back Better that we want to brief you on, and that has to do with drug pricing and more specifically with Medicare negotiation. Again, one of the provisions within the legislation that you may have heard the very most about within the news. It's oftentimes reported on, oftentimes discussed as over on the House side, it was negotiated on what would actually be included within the House legislation. And really the debate still continues even on the Senate side of how extensive Medicare negotiation should be. There are some within those who support the legislation that believe it should be very extensive. There are others who believe that it should be very narrow. And actually those who believe it should be very narrow were able to, on the House side, narrow Medicare negotiation down to only a very small subset of therapies that could be available within the Medicare program. So right now on the House side, that what they passed was a provision that would allow for negotiation for therapies that are losing their exclusive marketing capability. Every new drug that is approved in the FDA is able to be exclusively marketed for a certain amount of time, so long as it's a new drug, it's not a generic. And it's allowed to be exclusively marketed by that company as a monopoly, essentially, for a certain amount of time. It differs if it's a rare disease, a biologic, or a small molecule. What this provision would do is when that certain amount of time expires, the federal government is then allowed to actually negotiate, the Medicare program is allowed to negotiate with the drug developer for a lower cost that would cover all of Medicare, rather than currently only individual Medicare providers of Medicare plans, insurance companies, are able to negotiate with drug companies, and they're not able to use the federal government's negotiating power to lower the cost through Medicare negotiation. So because it's only a limited number of drugs, it's not new drugs, it's only drugs that have been on the market for a little while. And even from there, Medicare is only able to allowed to negotiate a certain number per year. It's not just any of these drugs that could qualify, it's only a handful per year. It's a pretty limited provision, all things considered. And consequently, it's a little ambiguous exactly how this could affect those with neuromuscular diseases. So it's something that we're still evaluating. We actually believe it'll be potentially more impactful for those in larger disease communities, because if Medicare is going to decide to negotiate, let's say, Lipitor or a drug for heart disease or high blood pressure or something that affects millions and millions of individuals, rather than a drug that affects just a handful of individuals like those in the neuromuscular disease community, we imagine that they're going to be choosing the larger market drugs. So it's another limiting factor that we can envision with this provision. Nonetheless, something that we're keeping a very close eye on as the Senate is considering whether this legislation, whether this provision will be included within the Senate version of the legislation, and then of course if the Senate's to move forward at all with this. One final thing I want to mention in this provision, well, it's a little ambiguous of overall whether the Medicare negotiation piece of this will be particularly impactful for those with neuromuscular diseases. One thing that's not ambiguous is that this provision also includes an out-of-pocket cap in Medicare Part D. For those in the Medicare program who are taking prescription drugs, and we're not going to get into the minutia of the Medicare Part D out-of-pocket payment structure. That's a whole different webinar that maybe we'll do at some point, but that's not today. But currently there is no out-of-pocket cap. This would actually add an out-of-pocket cap to Medicare Part D, which for those who actually take very expensive drugs can be very impactful. So that is something that we certainly support within the context of Medicare negotiation and drug pricing more generally. So it actually brings us to a close of all of the policies we wanted to brief you on today, but we still have just a little bit more time in our hour to talk about the path forward. If this is actually going to pass, the politics of all of this, all the main players. Mark, I'm going to turn it over to you.
Yep, thank you. I'll round this out. And we actually had a few questions come in about, is this really going to pass? What are the prospects? And, the path forward is still a little questionable. It's a little murky right now about what will happen in the next couple weeks or so. So of course, as we mentioned, this has already passed the House. So really we're focusing on the Senate, and a couple senators are really key. The way that the bill is going to be passed, bluntly, it's going to be with only Democratic support. And there's only 50 Democrats in the Senate, there's 50 Republicans, so the Democrats need every single one to vote yes if this passes the Senate or not. So that means every senator is key, but there really only a couple senators that are key. The first obviously is Joe Manchin from West Virginia. Even today he was talking about him, whether he supports this or not, or the timeline or not. So his voice and his point of view is crucial. If he's not on board, it's not going to pass. Another one to watch out is Kyrsten Sinema in Arizona. She's not been in the news a lot lately, but we still believe that she's a key player in this. And those two senators hold a lot of power, whether this will cross the finish line or not. So any senator can really can make a difference, but those two are probably the best that we need to watch out for. Also, because the Democrats are using the reconciliation process for this, there's a special set of rules. So only things in the bill that have a budgetary impact basically count. They're the only things they can put in this bill because of the way they're using to pass it. And who decides what counts and what doesn't? It's the parliamentarian, which many people don't pay attention to, but we have to pay attention to this person now because the parliamentarian will literally decide what can count and what cannot count, what can be in this bill and what doesn't obey the rules and cannot. So we have to see what their ruling is to see what can be included and not. We also have to talk about the holiday deadline. Even as of today, the Senate, the Democrats still want this to pass before the Christmas holiday. That is one deadline that actually will get senators to act, which is Christmas. They want to go home for the holidays. They want to see their families. And, it is a big motivator, but we'll see if they make that deadline or not. Right now it's looking murky, candidly, if they're going to make that or not. So, and then after that, we got to see what it looks like if it passes. What is removed? What has been included? Maybe what's been added? What does this bill look like if it passes the Senate? And is that palatable then for the House to revote for it? The U.S. House also has a slim majority. Candidly, this will only pass with Democratic support. We know that. But they have a small majority in the House. So will there be enough? Will the House like what the Senate does? Will there be enough of them to like it for it to pass? Many of them have pet issues. A lot of them really want paid leave to go in, for example. And if that's not included, will enough Democrats say, I'm not going to vote for it, and then we're done. So it's a very thin, it's a very thin line that this bill has to walk to get passed. So we will see what happens. The path forward is definitely murky, but we're confident that a lot of these things that we've talked about today will make it through the end. So what can you do now? We talked a lot of provisions in the bill, if there's something here that really sparks your interest, maybe it is paid leave, maybe it's Medicaid expansion, maybe it's getting rid of the sub-minimum wage. If there's anything here that you really you really think to yourself, I want that to get through, your senators need to hear from you, now. You know, they are negotiating as we speak. So if there's anything in here that you really want to pass, we hope that you want all of these to pass. I mean, we do. We want all these provisions to make it. But if there's a couple that are really tugging at your heartstrings, we really encourage you to take action. You can do that on our website. There's a screenshot of the campaign that we have that I put in the chat box, and you can write to your senators, but better, you can call your senators. And we have a call script for you. We have a sample message you can use to call your senators and urge them to keep these things into the bill. So we really encourage you to take action, call your senators, encourage them to have these things and keep these in the bill as they go through these negotiations. So we have a couple minutes left that we'd love to take some questions from the audience. Paul, maybe there's one you want to address now. But if anyone has any questions that they want to have us answered, we still have our two experts with us, so feel free to put them in the chat. But Paul, I know there's one on the queue if you want to address it.
Yeah, I'll just answer one question that Mike submitted for us, and that's if there are any provisions within the legislation that would keep disabled people who work who may not be eligible for Medicaid to get assistance to continue to work. It's a great question, Mike, and frankly, it's an issue that we're certainly advocating on, and it's something that is a priority for us. Actually, one of the things that we've really been focusing on this year in general, and will continue to be a focus of ours, is the intersection of those with disabilities and employment. And we have several programs that are launching, as well as several bills that we're advocating for, including the elimination of the sub-minimum wage, but also legislation called the Disability Employment Incentive Act that would incentivize companies to actually hire those with disabilities even further than currently within law. So it's not precisely what you're talking about. And if there are things that you hope MDA would advocate more on, please reach out to us. This is a great venue right here, but you can also email us at advocacy@mdausa.org, which is, I think, on the screen right in front of you. Yes, it is. And tell us what you want us to be advocating on. And we're going to turn all of your experiences and stories into our advocacy. So really appreciate you bringing that to our attention, to the forefront here for us to consider.
As we wait for any more questions to come in, if you want to get more involved in any of these things and just have a couple questions, feel free to email that address on your screen. I answer it every day. You're literally emailing me. So feel free to email us at advocacy@mdausa.org, and I will personally respond to you back about any questions you have. So we've got one more minute for any last minute questions.
Well, and as we're waiting for anyone to write back in, and actually, we do have a question here. Perfect. How does competitive integrative employment work, and how will employers be incentivized to pay people with disabilities a higher wage and provide more accommodations? Well, essentially, the grant program that the federal government would then be authorized and appropriated to administer through Build Back Better would fund states who currently allow for the use of sub-minimum wage. And this is something that states actually have to provide approval for. They have to provide a waiver to a business that actually wants to use the sub-minimum wage. The state would be able to, instead of approving the company to do that, provide grants to a company to transition the individuals who are currently employed at the company, who are actually being paid the sub-minimum wage, into a competitive wage. And this was really crafted this way to avoid potentially jeopardizing the job of the individual already working at the company, who very likely wants to keep their job, who is making a sub-minimum wage right now. They can keep that exact job, but not have to be paid the sub-minimum wage that, as we've said many times, we very strongly disagree with. So instead, this is actually a grant program that would assist with that. There is more to this, though, that actually isn't included within the legislation, the Build Back Better Act, but is included within a larger piece of legislation on this topic, the Transitioning to Competitive and Employment Integrated Employment Act, that includes not just the grant program, but also assistance from the federal government and states, the disallowance of further uses of the sub-minimum wage, and additional provisions that would take this even further. And if this grant program is to pass as part of Build Back Better, we're going to still advocate for all of those additional provisions to be included in the future legislation. But it's an excellent question, and thank you for that question. Mark, I think we may be out of questions today. We're already at a minute over time. So I just want to give, again, a huge thank you to Katie and Jason for volunteering your time today and your expertise. Your explanations of paid leave and these very esoteric and wonky healthcare access provisions were perfect. So really a big thank you to both of you. And Mark, I don't believe we have any additional questions. So you think we can close it for today?
I think so. And we just wish everyone a happy, healthy, and safe upcoming holiday. And we will see you in the new year.
Thanks, everyone.
Thank you, everybody.
Okay. Thanks so much.